For over 10 years, we have been trying to find genomic targets that create treatment options instead of chemo for our lung cancer patients. And that started with EGFR mutations over 10 years ago and has evolved to include less common variants like ALK rearrangements, ROS rearrangements, BRAF mutations. We know now that if we can find a genomic target, we can offer a potential for a durable response to a pill therapy with few side effects. And this is a really compelling alternative to chemo. Controls brain mets, improves quality of life. This is the pursuit of genomic targets that create treatment options. We now have FDA-approved targeted therapies for quite a number of targets. We have a range of EGFR inhibitors, some for initial treatment, some for resistance. A range of ALK inhibitors for initial treatment for resistance. FDA-approved treatments for ROS rearrangements, for BRAF mutations, and now PD-L1 IHC, an additional molecular target. And it means that we have all of these targets we need to test routinely for our lung cancer patients to create treatment options that are different than chemotherapy with its established toxicities and challenges. Beyond those standard of care targets, there are additional clear genomic drivers that create off-label treatment options or clinical trial options. These include KRAS mutations, well described but no immediately available targeted therapy, but many trials under development. MET splice mutations, they seem almost as common as ALK rearrangements, and there are many available MET inhibitors. HER2 insertion mutations, clearly drivers. They occur in young individuals and in non-smokers, but we don't have great drugs to target HER2, though we have drugs coming along. RET rearrangements, established RET inhibitors and new exciting RET inhibitors coming. So there always are going to be the targets where we have approved therapies, and then those additional targets where if you dig deep, you can try to find off-label or clinical trial options for your lung cancer patients.
I think most lung cancer patients who are never smokers have a different biology to their cancer than those patients that are historically smokers. And so for any subtype of non-small cell lung cancer, whether it's adenocarcinoma, squamous, or even never smokers with the rare small cell lung cancer, I would recommend comprehensive genetic profiling. Among squamous cell non-small cell lung cancers, anywhere from 10 to 15% of patients may have a driver EGFR mutation that you can treat with targeted therapy as opposed to chemotherapy. Additionally, BRAF inhibitors and HER2 inhibitors may be effective in about 5% of the patients who are never smokers with squamous histology. And so I think broadly patients who've never smoked, who have any form of lung cancer, should undergo comprehensive screening for various genomic aberrations, including at the very least EGFR, HER2, BRAF, ALK, and ROS1. Typically for our patients at UC San Diego Moores Cancer Center, patients will either undergo tumor-based tissue sequencing with a next-generation platform, often at least 300, 315 genes, 400 genes, and now with the availability of clinical exome, we'll often do this kind of testing in patients with a very specific scenario. For example, a patient who's never smoked, who has undergone 300, 400 gene panel testing, who still doesn't have a known driver mutation. Those are patients we may think about a whole exome-based sequencing strategy. Additionally, we'll often utilize cell-free DNA approaches. This is the so-called liquid biopsy that looks at DNA from the cancer in the blood. This is particularly helpful in patients who have difficult to reach tumors in terms of biopsy, or patients who are on targeted therapies such as EGFR inhibitors who develop resistance, for which we're looking for a specific resistance mechanism such as T790M.
My general take on lung cancer is that if you find a driver, that is the driver for that patient's cancer for the duration of their cancer, right? A KRAS mutation, an EGFR mutation, these don't vanish, they don't change. And so the chase is figuring out when is the right moment to find that driver and to make sure that your patients get effective genomic testing. I have patients where I test and I test again, not because I'm looking for a change in their driver, but because sometimes I am not trusting that my prior testing was complete enough or thorough enough, and I want to ensure that for those patients that are motivated, that are non-smokers, that are younger, that I make sure I turn over every stone to get them a genotype that creates treatment options for them. I will say that if you've treated an EGFR mutant lung cancer, we know that its dependencies can evolve and it can acquire new targets, some common ones like T790M and some rare ones like we've seen acquired RET rearrangements. We know that the genomic makeup of a cancer can evolve under the pressure of targeted therapy, and that can create new treatment strategies to overcome resistance.